everybody. Welcome to another webinar run by PsyTech. I'm really excited to have this discussion because it's about the carer's role in the treatment process of their loved ones, and I think it's very important. It's as all of these leading panelists will tell you, that it's a major part of the process and success of the patient. So I really just want to jump in. I'm going to introduce all of these amazing panelists, and then we'll jump into questions that I've prepared. And I really want to hear from you guys as well, because I know we have a lot of family members or main carers of patients themselves, as well as therapists. So I want to hear from you guys as well. So let's get started. First, we have Dr. Abid Nazeer. He is a practicing psychiatrist with board certifications in both psychiatry and addiction medicine, and is the Chief Medical Officer for Wesana Health. In 2016, he founded Advanced Psychiatric Solutions, ABS Ketamine, and opened the first dedicated outpatient psychiatric-based ketamine clinic in the Midwest, and has successfully completed over 3,000 IV ketamine treatments for mental health and substance use disorders. Dr. Nazeer designed his clinic model to incorporate comprehensive psychiatric services such as traditional pharmacotherapy, psychotherapy, neurocognitive testing, neuromodulation, pharmacogenetics, and outcome measurement as the foundation of ketamine therapy. Next, we have Ronisha Edwards-Elliott. She's the Community Outreach Coordinator at NAMI Chicago. She focuses her work on bridging the gap with the healthcare and mental health system, and specializes in serving adolescent young adults through the emerging adulthood stage of life as they transition into next stages, empowering people to pursue suitable workforce and post-secondary opportunities despite disability limitations, and equitable community engagement. Ronisha has dedicated her professional life to micro and macro level advocacy for diverse populations. Hi, thanks so much, Ronisha. Jennifer Danby is a qualified systemic psychotherapist working as the clinical lead in a child and adolescent eating disorder service in London, UK. Jennifer is also the study therapist on a trial at Imperial College London, looking at the use of psilocybin-assisted therapy for anorexia nervosa. As part of this role, she co-developed and leads the support person component of the trial. Jennifer is a supervisor and trainer in emotion-focused family therapy, a model that focuses on increasing caregiver involvement to support their loved one through emotional and behavioural difficulties. She is one of the founding board members for the International Institute for Emotion-Focused Family Therapy. And last but certainly not least, Dr. Adele LaFrance is a clinical psychologist, researcher, scientist, and author. She is a leader in the research and practice of psychedelic medicine with a focus on ayahuasca, MDMA, psilocybin, and ketamine. Currently, Adele is the clinical investigator and strategy lead for the MAP-sponsored MDMA-assisted psychotherapy study for eating disorders, and a collaborator on the Imperial College study for psilocybin and anorexia nervosa. She's also the developer of emotion-focused treatment modalities. Adele has a particular interest in mechanisms and models of healing, including spirituality, emotion processing, and the application of family-based psychedelic medicine. Whew, guys, and that's the end of the webinar. Okay, that's incredible. So I'm very excited. What I want to do now is I'm just gonna, anything that I may have missed out in terms of, you know, what you do day to day, what life is like, I'm going to give each of you a couple of minutes to get that started, and then we'll just jump in. So let's start with you, Adele.
I mean, you covered so much of it already, so I'll just add that I'm just really interested in understanding systemic approaches to healing, and in particular, how we can help family members be more involved in their loved ones' healing processes. You know, one thing that I'm really interested in is helping the field to understand why caregivers do certain things. Sometimes we can assume that caregivers shouldn't be involved because of different dynamics that are at play, but I'm really, really interested in kind of showing the field, you know, that there are alternative explanations and always, always, always good reasons to involve caregivers, you know, in the healing process. That's it.
Thanks so much. Ronisha, I'll go over to you.
Thank you, Deborah, for the introduction. So as you said, professionally, devoted to mental health and really bridging the gap for individuals to have health equity and mental health equity. But today I bring greetings from NAMI Chicago. We are an advocacy group that is really ending stigma for mental health. And for us, the role of the caregiver is so essential into recovery for those who are living with mental illness. So looking forward today to sharing ways that we support individuals in recovery and really support family members and caregivers in that role of helping the individual through their journey.
Thank you so much, Ronisha. Abid?
Thank you, Deb. Well, I'm happy to be here. I think this is a really good topic to discuss. My background, like you said, is a psychiatrist, and I think really just over the years of providing psychiatry services and ketamine therapy in our practice, I think that's where I really realized the importance of the caregiver and the family role. We're working right now at Wesana clinics to expand our clinical footprint, but we're also working on really trying to build up a caregiver program, whether it be within having those resources within one kind of clinic location. So it makes it easier to navigate for the loved ones, having services provided for them and available. There's like a lot of statistics out there showing how much higher risk you are of developing, symptoms of depression and anxiety and burnout if you are in a caregiver role. And also the importance of caregivers with the healing of the patient as well. So we're working to really build a way to measure that in a scale, a perception of improvement scale, as we see caregivers can sometimes perceive improvements in their loved one before even the patient themselves starts to feel better. So trying to measure that in a way is one of our goals. But I'm really happy to be here and looking forward to it.
Thanks, Abid. I want to dig into that more a little bit later about that process that you've been working on. Jennifer?
Hi. So I specialize in eating disorders, and I think in some ways in the field we're kind of ahead of the game in terms of involving caregivers, but particularly when it comes to like young children with eating disorders. But I'm really keen to kind of think about how do we incorporate caregivers as like co-carers, like leading in treatment, regardless of diagnosis and regardless of age. And so most recently, I've been kind of thinking about how to do that in the psychedelic field. And I think that it's a really exciting opportunity.
Yeah, we're definitely going to dig into the psychedelic part of it, because that's a whole nother bit that's like, okay, you've mastered this and now we're just going to throw in a bit of extra spice to make it interesting. So we want to get into that as well. I'm going to start again with you, Adele, to ask the role of the family historically, what it was and how we've evolved and why that's significant.
I mean, I think there have been different chapters over the last number of decades in terms of how families are involved in mental health treatment. There's definitely a rich history of family therapy of different types over the years that have really, gained a lot of popularity, traction, respect. But when we look at the treatment of individual mental health for mood disorders, anxiety disorders, eating disorders, historically, parents, family members could be cut out actually from the process. In fact, they coined the term parentectomies because of the belief that in some cases, people who were struggling with mental health issues were struggling because of the problematic family dynamics. And so these people would be hospitalized, for months and had no contact with their family whatsoever. And in the field of eating disorder, this was of particular interest. And some of our colleagues, were part of the kind of revolution of that view to show that when there's someone in the family who has a chronic or very serious mental health issue, the family reorganizes around the illness. So they end up in patterns that are amplified that potentially could be maintenance patterns, but it's a response to illness and a response to a lack of support, lack of resources in the broader community. And so, when people were kind of incorrectly assuming like, oh, the family is causing this problem, Now we have a much better understanding that no, they are responding to illness. They need and deserve support. And not only that, we can leverage the love within the system to optimize outcomes, to offer them, leadership roles, offer them support roles that are really clear and explicit, and that actually improves outcomes. And so we're still in recovery, though, from a pretty sad history of blaming parents. And if you look at any old textbooks of child psychopathology, there's a huge focus on parents being a problem. There's a huge focus on moms being a problem. And we're digging ourselves out now, to redeem ourselves and to kind of set the record straight in a way so that we can help units, we can help family units heal from intergenerational cycles of pain influenced by sociocultural goings on, if you look at historically, but also even in the present moment.
Yeah, healing our historical paths and stigmas. And I'm interested to hear your response, Ronisha, since you're so on the ground in community and you're dealing with so many different types of people about the challenges. You mentioned stigma yourself earlier in terms of involving the family. Can you talk to that a little bit?
Yeah, I think everything that Adele said, to echo that it correlates with stigma. We've been led to believe through historical factors that the mental health journey is an isolated event. When it is the family, it impacts all, whether that is through hereditary features where the mental illness is not just a factor of that individual, but maybe a family history that may have been skipped through diagnosis, or whether it's, the family responding to that individual. And so what that stigma has created is that sometimes we isolate people who are living with mental illness, as well as we make people who are caregivers feel isolated and alone and feel ashamed of that illness. When mental health is an everyday part of life, at some point in life, we all are going to encounter mental health, and it may look differently. Our experience may be differently, but we're all going to be impacted. And so family members have a very essential role in the life of someone living with a mental illness, as well as they are too trying to navigate and understand the experiences of that person.
Thank you. Abid, I'm interested to hear what you were talking about earlier about incorporating the family to measure the progress of the patient and the impact of the family can have on measuring that. Could you go in a little bit more, because you touched on it?
Sure. One is just starting from like when somebody walks through our doors, it's like, how did they get there? I mean, it's a very common scenario where, a parent or a loved one, a caregiver is bringing the person in, and that person might not even be bought into getting help at that time. Let's say I'm talking more about an adult population in our clinic. We see case by case below 16 years old, but we tend to see 16 and over. A lot of times the patient is very, pessimistic on how this treatment is going to help. They're suffering from treatment refractory condition like depression or anxiety or PTSD. So when the caregiver brings in somebody and they're kind of playing that role of, giving the patient hope and really saying, okay, you need to try this. And then as we start through this treatment, it's kind of a balancing act. We don't want to give false hope in a way. We want to keep a realistic expectation of how much a certain treatment can help. But at the same time, we don't want to take away hope either. So it's a balancing act, especially as you're going through, like, for example, like ketamine therapy, and let's say there's 6 treatments over a course of 3 weeks, and there's ups and downs during those 3 weeks. A lot of times it's the last effort. They're out of ideas, so they're really going all in on a treatment. And then when after a couple treatments, we're hearing from a family member that, like, we ask them how is the person, are they responding or not, and do you see improvements? And they'll be like, well, it's the small things we've noticed. We're so encouraged, like we've seen the so-and-so has not come down to eat dinner and to speak with the family in so long, or the person got up and showered today, called friends and got engaged. So we noticed that they would pick up on improvements and the patient would not necessarily feel that much different. I mean, maybe it's being in the sick role for so long, and you have a kind of really chronic kind of history of helplessness there because of failed past treatments. And then as the caregiver is noticing behavioral changes, then we see with time that eventually we might see improvement and we see rating scales start improving. And by the end of the treatment, everybody tends to be on the same page, which is why we're trying to measure what the perception is of improvement from a caregiver versus what the perception is for the patients themselves, and see if we can kind of validate those differences. But one thing is, once the patient shows improvement and now they're not suffering from the same level of morbidity from their depression, anxiety, we see suddenly the caregiver has a big kind of void. They have a role, they have an identity as a caregiver for it could be, we've seen 20, 30 years sometimes where it's spent, especially with mental illness, there's higher rates of caregiver fatigue and burnout and depression. And now suddenly when the patient is not needing that same level of, and I mean, sometimes it can get to a level of codependence, but in general, there's a support and a focus on that patient. And now what's the caregiver's identity? What are they going to do with their life as they have to adapt to changes in their family dynamics? So, I mean, those kind of parts of the equation are important in, if a patient is feeling helpless through the treatment, this is not working, we lean on those caregivers to really provide that extra level of evidence and support to us and to the patient and say, you did this recently, this was an improvement, and really try to highlight the positive aspects of the treatment for them and what they're noticing from it. So
that's really interesting. I think Abid just mentioned like two different important things. One was, I think we all feel that you think something's going on with yourself, but then someone else in the family will say, well, you did that, and we're talking obviously in a greater scale. And then you're also talking about the change in the relationship. And that balance changes. I'm interested to know, does everyone else in your different areas notice that as well? Whether, I guess, there's a success in the outcome or a failure in the outcome, it affects the carer. So who would like to kind of respond to that? Maybe Jen?
Yeah, I just wanted to pick up because you touched a bit on the burnout for carers, and I think it's so distressing to watch someone that you care suffer with mental health difficulties and not know how to support them. And I think lots of us have had training for years and years and years to figure out the field and learn skills to be able to navigate through different disorders. And so I think it's so important to be able to share that with caregivers, because when you give them things that they can do in those moments, they feel empowered, they feel more hopeful, they're more likely to be involved in an effective way. And actually then they're even more effective at it because of the relationship that they have with the loved one. So they're more likely to respond, and they also have more access to that person. So I think that actually when we actively involve them in the care, it reduces the likelihood of them going on to develop their own mental health difficulties.
Adele, I'd like to get into the topic of EFFT, emotional focused family therapy. Am I saying it correctly? Because you developed this whole thing, and it's so impactful and interesting, because I think people they think I've tried and it didn't work. I was involved.
Right.
And either I've made it worse or I'm giving up. So I'd love you to tell us all about it. And then I'd love to hear also Jen's response in terms of the study you're doing and how you incorporate it, and obviously from Ronisha and Abid as well.
Yeah. So, I mean, the model development really started from my own place of helplessness, actually. I was working in an eating disorder program at a higher level of care, and I was supporting parents to support their child transition from hospital, which included helping them eat, go on meals together. And I was really kind of disturbed because we had some of these patients who were very unwell, and their parents really struggled to feed them adequately, even though they knew they needed to eat more. even though they knew that their heart rate was, in the 30s or 40s at night. And I couldn't understand why there was such resistance, in following the treatment protocols. And I remember feeling quite frustrated actually with parents, be like, don't you get it? Don't you see what's needed? And, it turns out I was the one who needed to learn through humility about what was going on. And the more I interviewed these parents, the more research I did, I saw that these parents, it's not that they didn't get it. It's not that they weren't motivated. It's not that they didn't want to support their child to heal. It's that in most, if not all cases, they were worried that if they pushed too hard or followed through on these treatment recommendations, that it would cause so much distress to their loved one that their loved one might contemplate suicide, for example. And so there were these love-based fears that were fueling parents' engagement in what would be called therapy interfering behaviors or dynamics. And so I conducted some research to show that sure enough, when parents are afraid of something worse happening, like losing their child to suicide if there's too much distress, they had very low levels of empowerment, and they were more likely to engage in accommodating and enabling behaviors. And that research study for me was so important because finally there was like data to prove that there's no such thing as an unmotivated parent who doesn't get it. There's a parent who's afraid or who's steeped in shame or the fear of self-blame, and that those emotional reactions are influencing how they engage, with the world, with the treatment, with their child. The other piece, though, is that when we do recruit caregivers and give them a role to play, if it doesn't go well, then there's the risk of deepening their narratives of self-blame. Most, if not all, parents who have a child who's struggling, no matter the age, has a narrative of self-blame. And that can be further influenced by our cultural views of psychopathology. And so, that was another thing we had to think about is like, okay, well, if we involve caregivers and it doesn't always go well, or if it doesn't go well at all, how do we protect them from blaming themselves even more? And so that's one of the things that we talked about was like, okay, no, it's on us. If we involve a parent and it doesn't go well, it's because we didn't have the timing right. We didn't teach them the right way. We didn't have sufficient resources to support them so that we didn't inadvertently, hurt them in that way. All that to say, over the last, 15 years in developing EFFT, and really there's two areas of focus. The first is teaching parents and caregivers, including spouses, partners, alternative caregivers, emotion-focused and behavioral skills to support mental health and wellness outside of the clinic. And that involves behavioral support strategies, emotional support strategies, even therapeutic apologies to help heal old wounds. And then the other piece of EFFT is all about bringing awareness, targeting, and transforming what we call emotion blocks. So fears or shame that can influence parents' engagement in the therapy or how they relate to their child, so that we can free the whole family system, from some of those shackles. And then the last piece of EFFT, which I like the most, is a module for clinicians to then have processes to examine their own biases, their own stigma, around different caregivers or the involvement of different caregivers or their belief in caregivers, so that we too can acknowledge that we are human and we are vulnerable to these processes. And so that there are tools and techniques that we can use to maintain our belief in caregivers and family systems and support them in the ways that, they need it most.
Jennifer, thanks so much, Adele. In terms of the study you're doing, can you incorporate this when you're in a regimen of, it's a research, it's a trial, it has to be done this way and that way? What sort of freedom, how do you create it in terms of the support with the family?
So actually, it's amazing. At Imperial, one of the requirements to take part for a participant is to identify a support person that will enroll in the study with them. And that means that they will have 4 sessions with me throughout the duration of the study. And we give them different resources at different time points. But one of the focuses is teaching them the emotion coaching. So that actually what we know about eating disorders is that often it serves as a way of suppressing emotions and managing emotions. And what we know about psychedelics is that often it involves deep emotional processing. And so, somebody can walk in, suppressing emotions and walk out with big emotions. And so we need to be able to equip the people in their lives to know how to respond to that. So we teach them emotion coaching so that they feel like they have a toolkit to be able to respond, which will then hopefully embed the changes or the potential changes that could come out of the psychedelic work.
Okay, that's amazing. It's amazing how far we're actually coming. Ronisha, I'm interested to hear from you. Obviously, you see a whole range of people being in this community outreach. I wanted to know from you, how much of a role does gender, sexual orientation, culture, economic status, race have when you're dealing with family and caregivers? People don't all grow up the same way. You can have too much involvement or no involvement. So I'd love to hear from you, your thoughts on that.
Yes, all those factors play a tremendous role in the caregiver's role as they impact the social determinants of health. I think Adele and Jennifer both spoke so candidly to the emotion that, how fear evokes emotion and how we view the caregiver. And so I think that so strongly correlates to compassion fatigue and that burnout that we speak of. And oftentimes as helping professionals, we put that compassion fatigue and we view that for ourselves. But honestly, it is our caregivers who are really experiencing that compassion fatigue. And so when we take a moment to understand what they're experiencing on a day-to-day basis, or what it feels like in that midnight hour to have a child who is experiencing psychosis or hallucinations or hearing voices or not able to understand sound judgment, what does that feel like? What does that look like? And until you can take a walk in their shoes and normalize their experience, you really have no idea and really address your own bias. And then when we add that extra dimension of race and gender, as well as economic status, our lives look differently. And the ability to access help is so different. And so for NAMI Chicago, really what we're doing, our number one thing and way that we're able to help individuals is that they call our helpline. And so what we try to do and what I normalize in my practice is that when you're addressing a caregiver, let's validate their experience. Thank you for being the greatest advocate that this individual may ever have, and really taking a moment to understand those factors that are really impacting their experience or their ability to really help their loved one. Do you understand that this individual lives in poverty? And so it is unlikely that they'll be able to sit in the hospital with their loved one because they can't miss a day at work. That's an extra layer of stress that is on that individual and really impacting their mental health. And so when we take those into account and we really understand all of the holistic things that affect the individual and their caregiver and all the dimensions of their mental health, that's truly how we truly become helping professionals. And that's really how we address mental health layer by layer.
Thank you so much, Ronisha. A question for you, Abid. I would imagine managing expectations of the patient and the main carer is something someone comes in, especially now, I think with psychedelics and ketamine, which is the only really available psychedelic option. How do you manage the expectations as they come in and the results that come out for the family and the patient?
Yeah, I think it's important to start with just a lot of education to both the caregiver and the patient. I mean, in terms of, success rates, time frame to improvement, kind of explaining the ups and downs and what to expect through the process. That helps a lot, just the preparation part of it. And then the important part is that as you're going through then a treatment journey with the patient, that you do involve the family, you take the time to talk with them. It's not a sole focus on just only the patient. I mean, I think there is sometimes a concept of like, I guess, projection onto a family member, or there could be a sense of transference and countertransference. I mean, one aspect is, can sometimes caregiver, there's an assumption that they may be I guess, overbearing in a way. They're can be stifling to the patient's recovery, and that is sometimes based off of the provider's just past experiences, whether it's in their personal life or just from what they've seen with previous clients they've worked with. Or it could actually be the opposite, where there's a level of codependence and where there's a sense of enabling of certain behaviors that are trying to be, I guess, worked on in the treatment. So, I mean, the important part is just that we're able to identify that, involve them and educate them, and then really give them both space individually as well as together. That's important. So prior to COVID, we would have family members inside the clinics, inside the treatment rooms, pretty regularly. I mean, that was pretty much the norm in our clinic. And then obviously COVID had really kind of changed those policies. But I think, we always make exceptions. I know, because there are times where, especially through these newer treatments, it can sometimes help having a loved one in that room as a grounding influence, and just kind of somebody that can provide a calming kind of environment for the patient through that, an altered state of consciousness. So, we will allow that to happen when we need to, but the important part is that we involve the family all the way through whenever we can. I think Ronisha brought up social determinants of health, and that's very important in each scenario. I mean, there's data showing, based on income, if you look at caregiver, rates of depression, they go up as the income goes down, and it has a lot to do with access to care. I remember for most of my career prior to starting these clinics that we have now, I was working in inpatient settings a lot, and just to have a crisis like in the middle of the night with the loved one, having your loved one go to a hospital for mental health treatment, that can be traumatic of an experience all on its own for the caregiver. Especially if there's a situation where there might be violence or psychosis, and you're needing to call 911 and get EMS or police over to bring a patient to the hospital. That entire experience is very traumatic. And once somebody's admitted on an inpatient floor, I mean, it's crucial that their follow-up is planned out. And we don't even look to discharge out of an inpatient unit unless we have somebody on the outside who's playing that caregiver and champion role to ensure that there's a smooth transition out. So it's really crucial, really on that end as well, is that involvement can involve not just in an outpatient setting, but in really any setting, and even in the community setting. Like if there's an assertive community, we have ACT teams, assertive community treatment teams, where the team goes out to a patient, and many times that in that scenario, the patient does not have any caregiver, and they're suffering alone, and we play that role of a caregiver through that modality of an assertive community treatment team. So it's really crucial, I think, in kind of all aspects of the treatment journey.
Thanks, Abid. Guys, if anybody wants to jump in after someone's commented, please feel free to do so. We had, when people registered, there were some questions that I got, and one of them was really interesting. What do you say to caregivers who resist their involvement, saying that they're the person that triggers certain behaviors, but that's the person? So maybe Adele, you can start, and anyone else that wants to jump in.
I mean, we deal with it on both sides. On the one hand, some people don't want their caregivers involved, and they'll speak to that and they'll say no, I don't consent to having my caregiver involved. And we conducted a study 2 years ago where we had 33 people who said, I do not want my caregiver involved, for all the reasons. And I developed this very short intervention, 25-30 minutes. It's part of EFFT, looking at the resistance to the caregiver involvement, the fears, the potential shame that was fueling the resistance to caregiver involvement. And what we found was that after 1, 2, or 3 episodes of this intervention, this 25-minute thing, 28 out of 33 agreed to some type of caregiver involvement. it wasn't that they didn't want their caregivers involved, is that they were afraid of being judged, or they were afraid of hurting their caregivers, or they saw them burnt out and they didn't want to be, burning them out even more. And so when we were looking at the root of the resistance, we found that sure enough, they absolutely wanted their caregivers involved. They wanted to know that we, though, had in mind the implications, the potential issues, so that we could navigate those challenges. Now, on the flip side, gosh, I think Jen and I could write 10 books about different experiences of caregivers who did not want to be involved, but it's the same. At the root of their fear is like, well, there's two classic ones. One is like, I don't want to be involved because I want my child to be self-sufficient, independent, etc. And when I worked with parents of kids who had severe physical disabilities, I saw this all the time. They're really pushing their kid to like be tough and be resilient and be skilled, because they knew that one day they wouldn't be there. And so this harsher stance, this resistance to kind of doing more for them, was fueled by this love-based fear. And so when we can lean into that fear, connect with that fear, with that caregiver, we can help pivot them into a direction that's maybe more balanced. And then the other piece, the other really common one, is that some parents are really afraid of being involved because they feel like it's their fault. I did this, especially if there was a history of domestic violence or abuse, I did this. How can I be involved? How can I be part of the solution? And, and we validate, then yeah, like there's been some challenges, and they're real. There's a challenging family history here. And we check into their fears, we check into their shame, their self-blame narratives, again, to then pivot into a more balanced approach where that they can see that even if they are struggling themselves, even if they have an active mental health illness, a little bit can go a really long way. And that was probably the biggest and most humbling lesson I learned from my place of privilege, that I would want caregivers to be the best emotional supports, to be the best behavioral supports. And that's actually not necessary. A 1-degree shift in a family system, in a dyad, can actually lead to generation changing healing, for a family system, based on where they've come from, where they are now. So I always look for the emotion. What's fueling it? Can we go into that place? And like Ronisha said, validate that. And people talk about validation, like it's actually a really important tool. It's a really effective, not even tool, just way of relating to another human that helps them tap into their resources, that helps them to think more clearly, to trust, that this is possible, so that you can pivot together and start to find new ways of working together.
Deborah, if it's okay, I wanted to add something to that. So I think that along with that validation, sometimes education is the key to understanding the barriers to care. Okay, you feel like you're a trigger in that individual's life, or maybe they feel like you're a trigger. Let's take a moment to educate and understand, because this may be a new experience for that person. And so what we kind of do at NAMI Chicago is focus on recovery in the light of peers. That sometimes it's really the same way that we are expressing the need for the caregiver to be a support person to that individual. Sometimes it's the caregiver that needs support. So wrapping them in a community of individuals that understand what it is to experience someone or go through the journey of mental wellness. And so we really promote recovery groups and classes that are peer-led by individuals and caregivers who have that experience, who can validate that experience, who have walked in that individual's shoes or similar to that. And so what we see through that is that people come out feeling more empowered and equipped to be whatever it is that they need to be for their loved one. Sometimes support is really waiting until the individual wants you to be involved. Sometimes it's not you at the forefront forcing care, but it's you willing to be what they need you to be during that time of healing.
Thanks so much, Ronisha. It's interesting when you said before, Adele, about the pushing, and someone actually wrote in and asked, how do you find the balance between acceptance and support and pushing someone to get better. Because I mean, the way they put it's too easy to fall into the trap of comfort and complacency with too much acceptance and not enough pressure. So Abid, all of you can go for it. Abid, do you want to take it? I'd like to hear everyone's perspective, really.
Yeah, I mean, well, actually, I think one thing is to turn it around in a way. So one is and I'm curious as what the other panelists think and what their experience has been with this, but one is looking from a patient perspective first, like starting from that end, is there like I guess a willingness to to basically avoid more heartache for a caregiver. They're trying to prevent extra burnout. They have a sense of guilt in that dynamic, and that actually, I guess, leads to reporting improvement when there's not as much there, right? Like they're saying, I'm getting better. And I know there many times in cases of suicide, there's, like a feeling that, somebody's doing okay. They're doing better in the recent time before an event of suicide occurs. So it's important to know that, like, is there that kind of counter transference back, like, hey, I'm doing okay. You don't have to worry about me. Then the opposite is that you're getting, I guess, you're comfortable in a sick role and reporting that you're sicker and you're suffering more when you in actuality are feeling improvement. So it kind of, both of those need to be identified in a way and then addressed. I think in general, it's important that you kind of manage and balance both ends of it. I just think that they really need to be approached kind of individually and then together. I mean, obviously my specialty is not family therapy like Adele and Jennifer. They must have a lot of experience in this. It comes from more of the medical clinician point of view. But I'm curious to hear their thoughts on that. They sometimes will kind of reduce the role of a caregiver or increase the role of a caregiver based on those scenarios.
Good question. Who wants to take it first, Adele?
Yeah, and then I'll pass it to Jen. So I don't know that we would look at reducing, but transforming, so we kind of like assess the different relational patterns, assess the degree of anxiety fueling those relational patterns, especially when parents who are already burnt out. Like I'll say to them, I don't want you to do more. You can maybe even do less, but different, or same, but different, will help you relate to your loved one in a good way. And we actually developed this tool. It's called a relationship dimensions tool. And the caregiver rates where they are on these different dimensions. And one of them is, rushing to fix, or laissez-faire, always saying, I love you, never saying I love you. And so the caregiver can then start to see where their extremes are in themselves. And so that we can actually develop an individualized approach to transforming some of the ways that they relate to their loved one while preserving the good intentions, the love that's there between them. Jen, what would you add to that?
Yeah, I was just thinking that, I think we feel so strongly about the importance of bringing caregivers into the work that even if we don't have access to them, and we work really hard to have access to them, regardless of age, like I've just been working with a couple and brought that they were both in their 40s, and we brought in their parents that were in like their late 70s, because we know that involving them was just going to really strengthen the work. But if we can't have access to them, we bring them in like metaphorically, like we'll bring them in somehow into the work, like spiritually, or so I think that it is about how, not if. But I think I just wanted to pick up on something you said before, Adele, about like, resources. We know that some people aren't able to offer a lot, and so we find that one dimension, and that can be tiny. And I thought it might be helpful just to give an example of how small it could be. It could be that we write a text with that caregiver, and we cut and paste it in their phone, and we set an alarm, and we get them to send it to their loved one at set points in the week, which might just convey like, I love you, I'm thinking about you, like we'll figure a way through this. Nothing else other than that. But that 1 degree change over time is important enough.
Mhm.
So we really do think creatively about how to involve them, however small that involvement might be.
I would just add one thing to that, because when you talked about spiritual, like we don't often talk about spirituality in psychotherapy. And, I feel like one of the greatest gifts we can give clients, patients, those seeking treatment is a connection with the spiritual version of their parent. The version of their parent who's free of defenses, who's free of the pain of whatever they went through. And we have them like embody, the spiritual or the pure version of their parent, and to get to know that version of them. So if in everyday life they're having really challenging interactions, they always have a place to go home in terms of that knowing inside that, there is this spiritual version, though, that underneath those problematic interaction dynamics, there's love, there's goodwill, and there's hope, for change.
I actually watched one of Adele's videos. It must have been from about 6 or 7 years ago. I'm not sure how long, Adele. Don't worry, you look exactly the same. You said something that I just thought was so powerful, and it was this: not doing it didn't lead you here, but doing it can get you out. And I think that's just such an amazing thing. Are people hearing it when you say it? Is that a hard thing to pass over, because parents and family people blame themselves? It's very
like I did a workshop on caregiver self-blame, recently, and the caregivers had elaborate stories of how they were to blame for their child's mental health issues because of things that they did and didn't do, and they remembered them. In one of our activities, we asked them to zoom out 3 generations and to look at the pressures and the challenges that the 3 generations before them had encountered. And then we asked them to zoom out one more time to look at all the social and political pressures and traumas, that they suffered. And then to, again, look back at their individual behavior. Is there fault? Is this notion of fault even warranted? When we zoom out like this, it doesn't mean that those things that happened weren't hard, didn't have an impact. But when someone doesn't feel the weight of shame and self-blame and self-stigma, they're much better equipped, to deal with the here and now. And so that's one of the things that I really want to do, is help people to free themselves from the shackles of self-blame by looking at what their generation has been through, has survived, how they have thrived, and also looking at what was going on around them to make it so that their choices were restricted in terms of how they handled different situations in their family.
Does anyone want to add to anything? Everyone's not. I'm loving that everyone's nodding. It's just everyone agrees with each other. It's so special. Abid, now we're bringing family in, and now we're adding ketamine. Like, we didn't understand what was going on before, and now our loved one is having this experience that we really cannot relate to even more so. And now we're adding psilocybin and MDMA. And I know this is not necessarily Ronisha's wheelhouse, but I'd like to hear from you. How do you make carers and family and loved ones understand this incredible process that this person is now going through and be able to relate to?
Yeah, I mean, sometimes it's really easy on that front with the caregiver, because they've actually a lot of times have done a lot of research into newer treatments. They probably have been involved on this long journey of treatment for the person they're caring for. It might be a variety of medications and hospital stays, different treatments. And I think in those cases, they're usually aligned with me, and we're probably more focused on educating the patient in terms of what we can hope from this treatment. So that sometimes is easy. Sometimes though it's the opposite, and where there's there's obviously a lot of stigma attached to psychedelics and ketamine treatment, just based on other notions of is that a drug? Is it a party drug? Is this safe? It's new? It's experimental? So they're all valid concerns. And I think it just really goes to explaining the process in great detail, I tend to really, like, I don't shy away from explaining where the data is. I'm like, okay, I'm practicing an evidence-based approach, and we're doing this based on evidence that these new forms of therapy actually work. So they work better than what's been out there traditionally. And I think people respond a lot to that when they kind of hear where the data is showing kind of general success rates and efficacy. That is really powerful, because I'm not afraid to say this is likely the highest chance of success out of any treatment intervention that has been tried before. This is going to be one of the best shots at success. That statement alone, I think, goes a long way. People will run with that and attach hope onto that, okay, there is better efficacy and outcomes for this. Now, once, trying to explain, a bit, because it can be like after a treatment with ketamine, you have an experience, and you can actually have a loved one involved in your experience. Like, from a patient point of view, their dissociative experience can be kind of enlightening in how they view themselves and how they view themselves in the context of their family. So many times the patient will come out with new insights. I think the key is to help the caregiver, I guess, a patient needs integration therapy, but really, I think the caregiver also, in a way, needs to integrate what the person experienced that they're caring for. So,
thanks, Abid. Who would like to respond as well? Jen, you were writing things down there.
Yeah, I was just thinking, it's so important, I think, to get the balance, because obviously we're in the early days of researching the effectiveness of psychedelic medicine. And so I think, particularly when families have been on this really long journey, that sometimes they've tried so many different types of treatment. And so they come, with this hope, like, maybe this is the answer. And I think we don't want to discard that. We want them to have hope, but we also don't know. And so we don't want them to kind of come crashing down afterwards if it doesn't create the change that they hope for. But at the same time, like, going back to, I think, Adele's first point, is that families organize themselves around illnesses. And often the illness has been there for a really long time. And so somebody who has a psychedelic experience, they have this great opportunity for change. But if we don't prepare the system to also change with it, then sometimes it can shut down the opportunities for people to do things differently. And so I think it's really trying to get that delicate balance between encouraging change and being ready for it and open and going with it, but also, like, trying to measure people's expectations about what change might come from it. And I think in things like eating disorders, that's particularly important, because people are often quite ambivalent about change. So if people start jumping on top of it, it can scare them off. So we kind of want to get that fine balance.
Thank you, Jen. Did anybody else want to add to that? We're nearing an hour, everyone. So what I might do now is just get each of you to maybe give us some parting words, because I know we have some carers that are online at the moment. Perhaps just a lasting thought, or how they can reach you, or what especially you, Ronisha, next steps. What are your kind of parting words for us today on the topic, and then we'll sign off. So let's start with you, Ronisha.
I'll just say that my parting words will be validating the experience and really talking to that caregiver and helping them to understand that you're not alone on your journey, that there are others out there who have experienced what you experienced, who understand what you're going through, and that you are really doing the best that you can. You are your loved one's greatest advocate, and they are so fortunate to have you. And to those helping professionals who are here today wanting to learn more about, how to be a support person in their life, get connected, really engage in the community of those who are living with mental illness and understand their experience so that you can be a better helping professional for that individual and for the loved one. And I know that, Deborah, you are the reason now why I feel more embedded into psychedelics. And even though it's not something that I engage in treatment, in my treatment modality for helping individuals, I will say that recovery is recovery. And if it's going to help someone, it's worth understanding, it's worth validating, it's worth educating someone on and helping someone to feel comfortable with what they can do to get better.
That's amazing. Thank you so much, Ronisha. And the links to NAMI are in the chat for anybody that wants to reach out. Adele?
I mean, gosh, everything that was just said was so heartfelt, and so, yeah, just briefly, I would say that to the caregivers, we're coming for you, we're working hard to find ways to support you in the ways that you need to create structures, and to create an evolution of treatment to include more support for you, and the helping professionals, thank you for doing this work. Some people get really intimidated about systemic work like this. And so really grateful that you've taken this on, and just a reminder to kind of engage in practices to keep looking at our blind spots and keep looking at our biases, so that we can show up in the best way possible, not just for those who serve, but for ourselves too. And thanks again, Deb, for putting this topic on. It's really special. And for everyone else who's shared, I've learned a lot.
I'd love to, I know that you do some consulting. Is that right, Adele? If we want to put anything in the chat.
Yeah, I'm mostly trainings, so if people are interested in participating in EFFT trainings, to learn more about how to integrate some of these tools and techniques, then yeah, that's available. I'll throw it in while everyone else is.
Okay, thank you so much, Adele. Jen?
Yeah, I mean, I think for the helping professionals out there, I would just say from my experiences that it's always better. It always goes better when you involve the caregivers, regardless of the age, regardless of circumstances. They really increase the powerfulness of treatment.
Thanks, Jennifer. Abid?
Yeah, no, I enjoyed this a lot. I guess my parting words for caregivers is just don't forget to take care of yourself, and that there are a lot of, I guess, places you can, get support. Like Ronisha was saying, there are organizations out there like NAMI. So don't overlook self-care, and then don't, I guess, if you're caring for a loved one and who's ever treating that loved one doesn't want to involve you and you're a caregiver, I mean, I think you have that right, and you should not shy away from that to demand what is going to give your loved one the best chance of success, and that is being involved. So that's something where I think you don't be afraid to really go for it and take that bull by its horn and interject and get involved somehow. And if that person's not letting you be involved, then find somebody different, to be honest, because there are better ways of doing care, and the best way is an all-inclusive approach with the caregiver and the family dynamics involved. So yeah, and just like I said, self-care is important. So, but I appreciate this. The topic was great, Devin. Thank you for having us on.
That was beautifully said by everyone. But what gives me the greatest joy is just watching you all. This is what I saw the whole time. And we talk about involving the carers, involving the family and the patients. And what we're doing here and in all of our topics, I hope, is bringing together all the different medical professionals that are in this world, because everybody is often just working on their own little track. And when we expand the conversation to include everybody, there's no limit on what we can all achieve in mental health. So I'm really excited that you are all sitting here and nodding and participating. So thank you all so much. Thank you, Jennifer, Danby, Adele LaFrance, Dr. Abid, Nazeer, and Ronisha. It was just an absolute pleasure and endless information and help for everybody that's listening. So thanks again, everybody.
Thanks,
And
everyone.
we'll see you at the next PsyTech webinar. Have a great day, everybody.